Hello, my name is Naveen Citran and I'm an American Board of Internal Medicine certified interventional cardiologist and lecturer in adult medicine at the University of the West Indies. Today we will be discussing the acute coronary syndromes, and please note that this is a 10-minute review. We'll look at the following learning objectives, which includes the pathophysiology, territories, investigation, the TIMI risk score, acute coronary syndrome therapies, revascularization strategies, SC segment elevation, acute coronary syndromes, pathways, and management. First, we'll look at pathophysiology, and it is important to note that acute coronary syndromes constitute a triad of conditions, which include unstable angina, non-ST elevation MIs, and ST elevation MIs respectively. They can all be differentiated on the basis of their pathophysiology, electrocardiographic changes, and whether if they have normal or abnormal biomarkers. This illustration denotes the sequence of events from the quiescent state to the active acute plaque rupture state. It can show the influx of inflammatory cells, smooth muscle cells, which leads to the accumulation of a lipid core with a fibrous cap, which subsequently ruptures and forms almost akin to a volcanic eruption plaque rupture event. We'll look at the coronary artery territories, and these include, firstly, the left anterior descending artery, which are represented by leads V1 to V4, and this corresponds to the anterior territory. The circumflex artery is represented by 1, AVL, V5, and V6, and this is considered the lateral territory. Finally, there's the right coronary artery, which is represented by leads 2, 3, AVF, and this is known as the inferior territory. Please take some time to look and peruse through the notes on the right-hand column, as this forms the basis of many multiple choice questions. It may seem as detailed and minutiae, but I can assure you it is very important from an exam perspective. Some cardiovascular investigations include routine laboratory investigations, definitely a 12-lead EKG, and one can consider pursuing a right-sided and posterior lead EKG for inferior posterior acute coronary syndromes. A chest X-ray is critical to rule out acute aortic dissection and any co-incident conditions such as pneumonia. A 2D transthoracic echocardiogram is important for assessing the left ventricular ejection fraction, any regional wall motion abnormalities, or valvular heart disease. Please note that the following conditions are considered critical, and urgent coronary angiography is usually accelerated within 24 to 48 hours if the patient has one of these conditions. The more important ones include recurrent ischemia despite medical therapy, severely elevated troponin levels, severe ST depressions, a markedly depressed LV dysfunction, life-threatening or lethal arrhythmias, or recent coronary interventions such as PCI or CABG. This graph illustrates cardiac biomarkers, and please note that troponin I and T are considered the markers of choice. The older or obsolete cardiac biomarkers include myoglobin, CK-MB, CK, and LDH. It is important to know that troponin I and T, there is an 8-hour delay before they turn abnormal, and it takes up to 2 weeks before it disappears from the body system. CK is not reliable as troponins. However, they tend to rise earlier than the troponins. Next, we will discuss the TIMI risk score, and this was derived from the TIMI 11B trial. It is considered to have 7 criteria, and there's a point ascribed to each criteria. It portends a prognosis based on your cumulative score of 0 to 7. Score of 0 to 1 corresponds to 4.7% risk of major adverse cardiovascular events, which by definition includes death, myocardial infarction, or urgent revascularization, whereas a score of 6 to 7 corresponds to a mortality or major adverse cardiovascular event rate of 40.9%. Next slide is very important, and this is probably the most critical slide that on this presentation, and includes the pharmacotherapies. It is instrumental to institute all 7 of these medications as soon as possible without delay once there are no contraindications. This includes aspirin, commonly clopidogrel, low molecular weight heparin, beta blockers, ACE inhibitors, mineralocorticoid receptor antagonists, and high-intensity statins. As you can see, the relative risk reductions are quite substantial, and these are evidence-based trials which show that these medications are crucial in improving mortality and patients' survival. Next, we'll look at the 2 major revascularization strategies, which include percutaneous coronary intervention and coronary artery bypass grafting. As you can see, there are different niches which work better with different strategies. CABG is the preferred modality in triple multivessel coronary artery disease, left main disease, high syntax scores, which indicates angiographic severity, type 2 diabetic patients, chronic kidney disease patients, and patients with depressed left ventricular functions. PCI is considered superior in single vessel coronary artery disease and ST elevation segment acute coronary syndromes. With respect to ST segment elevation acute coronary syndromes, please note that a new left bundle branch block is considered an ST elevation equivalent. It is also important to note that there are several mimics or masqueraders that can appear similar to an ST segment elevation acute coronary syndromes. These also commonly present in multiple choice questions for your final exams. So please take a minute to review this panel on the right. With respect to ST elevation acute coronary syndromes, there are 2 major strategies which include primary percutaneous coronary intervention, which is the preferred or optimal strategy, or the pharmacoinvasive approach. One must consider whether or not there is a present PCI-capable facility and if the time to transport to such facility is less than 120 minutes. If so, the patient should go down the route of primary percutaneous coronary intervention with a door-to-medical device time goal of less than 90 minutes. If there is no such PCI-capable facility, or indeed there is one, however, time to transport is greater than 120 minutes, which is commonly what occurs in Trinidad and Tobago, then these patients should receive the pharmacoinvasive approach, which is thrombolysis followed by urgent coronary angiography with PCI within 24 to 48 hours. Please note that the door-to-needle objective time is less than 30 minutes. Next, we'll speak about tenecteplase, as many questions commonly come on tenecteplase. You have to know that it is fibrin specific, there's a short half-life, and it's a single IV bolus administration. It is also only effective in 70% of patients in the pharmacoinvasive approach. These are the contraindications and cautions for fibrinolytic therapy in patients with ST elevation MI. On the left panel, there are absolute contraindications, and on the right panel, there are relative contraindications. As you can see, there are a multitude of each. Please take some time to review this slide, as many questions on your final MBBS exams include details from this slide. This is our final slide, and it speaks of the complications of acute coronary syndromes. These include sudden cardiac death, chronic heart failure, recurrent acute coronary syndromes, life-threatening or lethal arrhythmias, left ventricular mural thrombus, aneurysms, pericarditis or Dressler syndrome, and there are also the potential for mechanical complications such as papillary muscle dysfunction and the formation of ventricular septal defects. This now concludes our discussion of acute coronary syndrome. Please note that there's some caveats for this presentation. 1. It does not include all the necessary detail. 2. This is just a basic review when you are perusing your work. And 3. Take some time to look at the details on the slides, as this is for your benefit. Many of the questions in the final MBBS exams are structured on this slide. I think it is a good idea to take your time and really absorb this information. Thank you very much.